Good evening, and welcome to the Care and View, the online health and social care platform free to access to absolutely everybody. Before we get started, don't forget to hit that like button. If you're watching us on Facebook, give us a follow. Give us a follow on LinkedIn. We're on X, we're on Insta. We are on YouTube. That is the most important. Please do subscribe on YouTube. If you think to yourself, oh, I don't have Spotify. Oh, I don't use Amazon Music. Oh, I don't have Apple Music. Do not worry. Our podcast is also now live on YouTube as well. So if you give us that subscribe on YouTube, you will also have access to our podcast through YouTube Music. Super duper exciting for ourselves. We are literally taking across all the platforms. www.thecareandview.co.uk. Visit that site that has all of our free resources, all of our past episodes, our podcasts, our sponsors, our suppliers. Really excited that one of our people on our supplier list is joining us tonight in our guests. And as always, we do this for absolutely nothing. We do this for free. It doesn't cost you anything to access any of the resources that we put out there, and we do that through our fantabulous sponsors. So I do want to give a quick rundown of our three main sponsors at this moment in time. So we have Prosperwell, Smooth Tea, Toby, absolutely fabulous company. They are the leading digital marketing agency in the country. Do go and check them out if you are thinking, how do I improve my marketing for my social care business? I'm having a bit of a dip. Go to Prosperwell. They're absolutely amazing. We have CBAT. This is the brainchild of the Hulk, aka Paul Blaine, who is on a bodybuilding mission at this moment in time, doing some absolutely incredible self-work. But the CBAT team are there for all of your social care training needs. Please do go check them out. And obviously, Attis Care by Attis Insurance Brokers, comprehensive care cover comprehensive care coverage and proactive risk management. Everyone hates talking about insurance. Social care and insurance just do not get on at all. Attis Care make it all easy for you. So please do go and check them out. I think that's everything we've got to say. We have got a podcast around the Violence Protection Act. Mark, please correct me on this.
Yes, the new Worker Protection Act with Stephen Scone. It was a really informative podcast, and I listened back to it the other day while I was driving to Heathrow for the Care for it. And there's just so many tips to get you ready for when that comes into place later in the year. So I definitely recommend going to check that out, because I think there's a lot more emphasis on what employers need to do to protect the rights of employees, more than we've ever done before. So yeah, no, definitely a worthwhile podcast to listen to.
And if you subscribe to our YouTube channel, you can access it directly through our YouTube channel, or YouTube Music, or Spotify, or the usual other podcasting places where people go and listen to their podcasts. Oh, good evening, Mark. How are you?
Yes, not too bad. Good evening. How are you?
I'm good. I like symmetry, Mark, so I'm just going to squid you over to the right if that's okay. I like a bit of symmetry in what we're doing. I'm absolutely fine. Thank you so much for asking. I am going to admit, Hannah Montgomery from Grace Cares, please put your fingers in your ears. I have just put my heating on. I know that's not sustainable, but I am very, very cold. This is so cold.
Oh, I'm not going to lie. Mine's on tonight as well. It's definitely gone cold. Yeah. Where's the summer? That's what I want to know. Where's that sun gone from the weekend?
Well, it's solstice in 9 days, isn't it? So we've got 9 days for the country to sort itself out and for summer to start. But my heating is set at a comfortable 23 at this moment in time. I am loving it. So tonight we are talking around diabetes footcare and what are we missing. I think for me, this is a huge one. Obviously, I work in nursing homes, and I've got 4 nursing homes under my belt that I oversee. And when we talk around diabetic care plans, and how we support people with diabetes, foot care is obviously one of those huge important things we need to focus on, but sometimes goes under the radar because we get ourselves sort of embroiled in the whole medication side of things, the symptomatic side of things, and that generic sort of, how do we just actually look after these people and their skin? And how is it a daily task for everybody in the home, and not just say our nurses? How is it for everyone to get involved in this? Mark, I know you're home care, so this will apply very much to home care settings as well, especially when you're in that home for such a short period of time. Picking up on warning signs will be absolutely paramount to providing that best quality care. So I'm just going to introduce, I guess I'm not. I'm going to say, hi, Julie, who are you and where are you from? And then you're going to do a much better job at introducing yourself than I ever will. So, Julie, who are you and where are you from?
Thank you, Adam. My name's Julie Rayner, and I've got the wonderful title of Care Quality Governance and Compliance Director, and I work for Hallmark Care Homes. I've worked with Hallmark for almost 9 years now. So yeah, I've worked very closely with both Lynn and Gareth recently. So I'll let Lynn and Gareth introduce themselves.
Thank you so much, Julie. Lynn,
Oh,
who are you and where are you from?
Right. Sounds like I've got Cilla Black in the room there. I'm Lynn from Duet Diabetes. So not surprisingly, the giveaway is the title in our company name is, well, we're a CPD approved provider around diabetes training. And one of the areas that we spend a lot of time talking about is foot care, diabetic foot screening. So as well as delivering everything from diabetes awareness and insulin and injection technique, I would say we probably spend our most amount of time talking about feet because they've become an increasing hot topic, I think, and particularly around in the care sector as well.
Honestly, and if you do want to know more about Duet Diabetes, just head over to our supplier list on our website, and Duet Diabetes are on there. You'll be able to get all of their information, visit their site, and get them booked for training. Because, come on, I don't know if anyone's going to get this reference. I'm glad you got the Cilla Black one, but this is like a Quentin Tarantino's dream, this episode tonight. Quentin Tarantino, a director, is hallmark of his directing shots, his feet. He's got like a huge foot obsession. So I'm sure Quentin is probably booking in somewhere, watching this show in sunny California, I should say. Gareth, who are you and where are you from?
I'm Gareth Hicks. I live in Wales. This is where the sunshine is, by the way, Adam. I'm looking out at a blue sky and the sun is just setting over there. Just to let you know, the sun shines on the righteous. I qualified as a podiatrist many, many years ago, back in the 80s. I worked in the NHS. I worked in the private sector, did a lot in sports medicine, did a lot in diabetes. These days, I basically talk for a living, so I educate. I'm fortunate enough to work with Lynn in Duet Diabetes, so she basically does all the work behind the scenes, sets up these days, and I go along and talk feet for a few hours and hopefully improve people's knowledge.
Well, welcome to the show, everybody, and thank you so much for giving up your Tuesday evening. I can't imagine there's much on the telly box these days that's worth watching. That isn't the news or depressing election results from France and Europe, which topic of conversation for another night, I think. But where do we start? Julie, let's start with yourself, because obviously you've done some work recently with both Gareth and Lynn. So just tell us a bit about the journey that you've been on and why you've reached out to Gareth and Lynn.
Right. So Lynn and I, it was about 2020, wasn't it, Lynn, when we were both involved with the National Advisory Panel for the development of guidelines for the management of diabetes in care homes. And that was led by Professor Alan Sinclair. So that was a big bit of work, and it was looking at, developing guidelines to support the care sector in managing type 2 diabetes. So Lynn and I met via that. And I've always had a great interest in the management of diabetes and ensuring people who are living with diabetes have the best quality of life possible. So once that work concluded, I picked up with Lynn to talk about how we could raise awareness of diabetes management within Hallmark care homes. So, obviously with my interest in that area, we obviously had a management of diabetes policy. We had quite good diabetes management care plans, but there was certainly a place for increased awareness across all of our team, nurses, senior carers, anybody in the home. We needed to raise the awareness of diabetes. And when we were having the conversations around the content of that training, who was going to be involved in that training, obviously we talked about foot health, and that area of assessment and management within diabetes care was something that certainly, happy to hold my hand up, in Hallmark, we didn't concentrate on. And I don't think we were unusual within the social care sector around not really focusing or not putting a lot of focus on foot health for our residents who are living with diabetes. So that's how the original training programme came into being within Hallmark, and both Lynn and Gareth spent quite a bit of time in our care homes delivering training to the team, and obviously that did involve the health of the foot. And the feedback we got from the team was so positive, you know, particularly around Gareth had them doing the foot assessment on each other, you know, so they were having that real life experience of doing that risk assessment. And then, you know, following that, we have introduced the foot assessment tool, the risk assessment tool within all of our homes. Sits on our electronic care planning system. So, you know, within our management of diabetes policy, it is defined clearly how we are going to assess the risk of, you know, peripheral neuropathy in our residents who are living with diabetes. That's a quick gallop through, Adam. 4 years.
Thank you very much. I mean, I think, first of all, I think it's great that actually you recognise that this isn't something that you previously did. Because when you were talking there, I thought, actually, I think if we got together, the staff team, and look at our training and bits and pieces, actually, it's probably not something that would definitely pop out straight away. So I think it's great, actually, that there's that awareness there that actually it was something they weren't doing, but it's now something you've really embedded into the culture of your service. Secondly, I think it's great that you managed to get your staff to get their feet out to each other, because I can imagine that wasn't an easy task in itself. I know what people are like with feet. They either love them or hate them, and I think more people hate them than love them.
I think, sorry, I was just going to say, I think that what came across in the training, and I know Lynn said this to me afterwards, is that the number of our team who either were living with diabetes themselves or knew somebody who was living with diabetes, and that learning and that awareness actually did then carry through to their outside of work lives as well. You know, so there were so many benefits to that training for the team.
Oh, absolutely. I always think that's real positive, isn't it, when it kind of impacts your personal life as well as your work life. Lynn, sorry, did you want to come in?
Oh, yeah, I just wanted to say that everybody was warned that they might be baring their feet, so that kind of helped a little bit. But also, we're not ogres. If people really didn't want to bare their feet, we didn't force them, did we, Gareth? So.
No, it wasn't mandatory. It was purely voluntary.
But yeah, they did, and I think people saw and realised the benefit of doing that, of having that hands-on feet, so they could properly embed that theoretical knowledge that they'd learned to actually put that into practice whilst Gareth was in the room, knowing that where they're feeling for pulses, where they're assessing for neuropathy, all these other aspects, other things that they're looking at. People soon realise that actually, if we all get our feet out and we do this with each other, it's going to be so much more powerful and impactful, and we're more likely to remember it than if they didn't. So actually, you know, there were great engaging groups. So there was a lot of benefit.
And I think, you know, I'm a nurse, and as a nurse, you know the importance of foot health. You know the complications that of peripheral neuropathy, and you know that people who are living with diabetes have got a higher incidence of having foot damage. But we know that, but I don't think many of us really had the experience of doing that assessment, finding the pulses, being able to understand clearly what it was you were feeling. We use the monofilament test as well. And again, you know about it, but you don't necessarily have the experience of using that test and interpreting what that test is telling you. You know, so the upskilling in the team was, you know, what was really significant.
No, thank you. And I want to come back to the monofilament in a minute, just so we can upskill other people. But Adam and I, one thing we talk about on the Care and View a lot is the impact of the people we support in our teams. And I just wondered, before we kind of move into kind of the foot health conversation and an awareness piece, if you could just talk, Julie, around kind of what that impact's had to both your team, obviously around knowledge, but also to the people that you're supported and probably to their families as well.
Yeah, I think, one of the outcomes, has been the increased confidence of our team. Being able to have those professional conversations with the specialist teams. So we've got examples of team members who've undertaken a foot assessment, have identified some areas of concern, whereas previously they wouldn't have picked that up. They've picked it up and they can have that conversation with the GP, around the fact they've used the monofilament. This is what they found. The pulse was, weak, or the pulse was absent. It's just given them that confidence to have those professional conversations. And that's about foot health, but also around the general management of diabetes as well. They talk to specialist teams, the GPs, with a lot more knowledge about what the blood glucose reading is telling them, how the resident is presenting. So I think it's just that raised awareness, that increased confidence that we are seeing is having a positive impact on people's health and well-being. Clearly families, if their loved one is living with diabetes, to know that our team have got that knowledge, that awareness, that does give people a lot of comfort that our team know what they're doing in that area of care.
I mean, there's a lot to consider here, isn't there? There's a lot to take in. There's a lot to sort of wrap our heads around. And I think for Mark and I, we want this episode, as well, all of our episodes, to be something that can educate and inform everybody. So let's just go back to basics very, very quickly. And I'm going to come to Gareth. For people living with diabetes, what are some of the most common foot complaints and foot conditions that we should be expecting? What are the most common ones that are experienced?
Well, with the diabetes patients, they're the same as the non-diabetes patients. They'll have possible nail problems, callus problems, etc. The trouble is, in diabetes, particularly if the patients don't have very good control, then when they start to develop high blood sugars, that's when complications come in. And the complications can end tragically sometimes with ulcers or with amputations. But the sort of things that a diabetes patient will have will be similar to other patients. So they'll have their corns, their callus, inguinal etc. It's just that with the diabetes patients, they're slightly more at risk of things getting a little bit worse.
So it's any sort of open wounds, open sores on feet. We've really got to start thinking about with people with diabetes. Actually, we need to keep an eye on this because the chances of this healing.
Yeah. As soon as you break the skin, there's a portal of entry for bugs and bacteria, etc. So all of us should look after an open wound, but particularly with the diabetes patient, then if there is any compromise with their blood supply, for example, it'll take a longer time for it to heal. And in some cases, with diabetes patients who are previously undiagnosed, that can lead on to diagnosis. So we've had patients in clinics before now where you're talking about this wound. They said, "Oh, I've had it for weeks and weeks." You're thinking, "Well, why isn't it healing?" And lo and behold, they've been a hidden diabetes patient for a while.
Wow. And finding out through something like that, and actually what other complications have they had in that time where they've not picked up those signs and symptoms of diabetes? I mean, as a side note, sorry.
I was going to say, with the type 2 in particular, that tends to be a longer onset. So with your type 1 diabetic patient, they tend to have a shorter period of symptoms and they're more severe, so they tend to get picked up quicker. With the type 2 diabetes patient, they can be living with it for months or even years before they realize, and very often they've sought help because of complications. Sometimes it can be with retinopathy in the eye. The high street opticians have picked it up. Sometimes their podiatry clinic or private practice may pick it up, saying, these pins and needles in your toes, it could be diabetes, or it could be this open wound that's taken a while to heal. Or in your general clocking in with patients, you ask them about their general health, and they might say something like, "I'm drinking an awful lot recently, and I'm going for a pee a lot," this sort of thing. So those sort of things are something that all clinicians are listening out for.
Is there a stigma around seeking out a diabetes diagnosis, do we think? I'm just thinking with you saying around how people might not find out until they've got wounds on their feet. Do we find that this is just a question I'm positing right now? Is there a worry that people might have, actually, I'm not going to go because I'm embarrassed about a diagnosis?
I'm not sure it's embarrassment. I think a lot of it is fear. Because very often when patients are told, sorry to say, you're now a diabetes patient, sometimes they then switch off and think about the guy down the road who may have lost a leg, or somebody else who became really ill and then passed away or something. So it's a sort of human reaction to think of the worst possible thing. But what we try and promote with the Duet Diabetes course, yes, we can deal with complications, but diabetes it can be a well-controlled condition these days. So we've got, I'm not sure if anybody's into tennis, but one of the French Open players was a type 1 playing the other day. We have type 1 Premiership rugby players, football players. Steve Redgrave was type 1 when he won his 5th gold medal. So there are a lot of treatments and new technologies that will help the diabetes patient. But I think, yes, certainly when I was back in last century when I qualified, there was a little bit of a stigma, but I'm not sure so much it's embarrassment. I think it's more fear.
I think if I can also bring in as well, I think also for some people for type 2 diabetes, they don't necessarily know that they're living with it, because some of the symptoms, Julie, you might agree with this, with older people, that we all perhaps get a little bit tired as we get a bit more older, and especially as you're sort of going into your 70s or 80s or beyond. As we age, we might find ourselves, nipping to the loo a little bit more frequently. Some of these symptoms you can miss, and you just think, oh, it's just part of getting older, actually. And so I think that can partly play into it as well. But then when people are picked up, and it's one of the things that the National Advisory Panel on Care Home Diabetes has highlighted, as anybody moving in, it should be something that is screened for. But if they pick it up and they help that person, manage and get more normal blood glucose levels, they can suddenly feel a lot better in themselves. Some of that fatigue might be improved. Some of these other symptoms can be sort of relieved a bit through either looking at maybe some of their diet aspect, or even if they do need some treatment. So yeah.
And interestingly, we're doing a bit of a trial in 3 of our care homes, which is testing the hypothesis that there are a number of people who move into care homes who've got undiagnosed diabetes. So what we're doing is we are screening every resident who's currently living in these care homes, obviously with consent, and screening residents on move-in as well. We've had to get the agreement with the GP to do this, because obviously if our screening highlights a risk, then it has to go to the GP to do the fasting blood sugars, whatever else they need to do to get a diagnosis. And at the risk of being controversial, I'm not sure what you feel about controversy on your Caring View podcasts. It's a number of GPs were very reluctant to support that. I don't know whether it was the concern that all of a sudden they would have a number of people who have now been diagnosed with type 2 diabetes, on their register, but it wasn't easy to get GPs to agree to support us in this.
They've probably not accounted for it in their budgets or quotas.
You said it, Adam. Thank you.
We don't mind causing controversy on here. No, I'm totally hearing. In fact, you took the thought out of my brain as you were talking then, Julie. So I was thinking to myself, this show's all around tonight, identifying sort of concerns in feet management for people with diabetes and that sort of care management of diabetes. But actually, there has to be some due diligence from us as a team to go, well, actually, this person doesn't have diabetes that we know of, but are they showing any signs and symptoms of it? And are we screening our residents to go, actually, yeah, they are potentially a bit more incontinent at the moment, but that's because they're going to the toilet a lot more. Wonder why that is. The wounds aren't healing as much at the minute. I wonder why that is. The mood seems to be fluctuating. I wonder why that is. All these things together. Actually, is there a diabetes issue here that we've not identified that we need to, that might actually prevent any further issues further on down the line?
And I think, other thing that we've taken on board from, the work that we've been doing with Duet around foot health and the links with falls risks. So if a resident is losing sensation in their feet, or as Gareth described, pins and needles, changed sensation in their feet, then that needs to feed into the falls risk assessment as well. Yes. So that's been another angle that team have gone, oh, wait a minute, that actually could be a risk, could heighten the risk of falls. So there's lots of interconnectivity, isn't there, when you start to raise awareness and learn about a condition.
Yeah, no, most definitely. I just one last question before I come to Mark, who's probably going to ask about the feather tickling your feet, or as we call it, the microfilament test. I just think it'd be much better if it was like a feather, and like in the cartoons. I just want to talk around tonal issues with people with diabetes and skin management. So I know it's a hot topic at the moment within pressure care and tissue viability, skin tones, and how we identify things. And Lynn, Gareth, I don't know which one of you are probably best placed to answer this, but is there or has there been any work around skin tones and diabetes foot care? Is there anything that we're aware of that we can share tonight?
Yeah, sure. Shall I go off on one here?
You can
it's a little pet subject of mine, mainly because a very good friend of mine is involved in the publication. But for a while, there's a fantastic couple of ladies called Lakshmi Doon-Moon, who's a tissue viability nurse, and Simone McConney, who's a podiatrist. They got together. They've done a lot around recognizing things like inflammation. In Caucasian is very easy. There's a contrast there. But in dark skin tones is not so easy. So you just got to spend a little bit more time looking at things. And with those patients who have dark skin tones, I think we're all a little guilty about not spotting things a little sooner. So they deserve a little bit more attention. So both Lakshmi and Simone presented a poster at the Royal College of Podiatry last year. And just last week, the Diabetes Africa, there's a free online handbook that you can download. So you go to the website. We've left it. Lynn has been good enough to put the reference in. You go to the website. You just put your own email in. They're not going to hassle you with lots and lots of spams and all that sort of nonsense. But you can download a guide there that'll take you through the variety of skin tone that we have with all our patients these days. It's a really good resource.
Well, we'll definitely make sure that I think Mark's already beaten me to it. He's put the link out there in the chat for people to be able to go and access it. It came up on the screen as well. And I'm sure we'll share that at some point on socials. I'm going to be downloading it straight away and sending it out to all my nurses and managers because I think that's a really, really great resource. I'm glad I asked. I think that's really some really great stuff.
Well, it's something to bear in mind. Working with these ladies and also Professor Sinclair, around about 1 in 4 patients in a care home will have suffer with diabetes. That's likely to increase. But also you have to bear in mind with diabetes, then if you're from an ethnic background such as South Asian, Chinese, Afro-Caribbean, you're a higher prevalence within that ethnic group as well. So that's something else to bear in mind. This is why we need to take a little bit more time examining people.
Yeah, definitely. Mark, I'm going to come over to you now for questions. And I was thinking about you when I thought about screening people in homes for those symptoms of diabetes. And obviously I work elderly, but you've had an LD background and you've had younger adults that you've supported. And I suppose that's a demographic where, again, it could be quite a bit of a concern because there are people with disabilities who are more susceptible to developing diabetes and being able to screen that internally as well. Have you ever experienced anything like that whilst working LD, or was there a deficit? Do you know?
No, I definitely think there's a deficit. And I think it takes us back to the beginning of the conversation this evening where we were talking about actually just that lack of awareness and that lack of thought of actually let's include this in our training. And I've spent half of my career in LD across various different services, and actually none of them have had foot health as any part of the diabetes training or separate standalone. And I think it just highlights the importance of actually everybody that's watching tonight actually taking that back to their services and looking at what they can do to implement something and get in touch with, obviously, Duet Diabetes. I was listening to everybody talking, and I put on my home care hat, and I was thinking it's great if you know that you've got diabetes and what to do in the screening. There'll be a lot of people watching tonight that don't have any risk assessments already in place, don't have that training. Is there anything you can implement in terms of routines that we can encourage people to do, either staff or for themselves, that would be beneficial for their positive, good foot health? Lynn, I'll come to you, or Gareth or Julie, anything that you can recommend?
Or I'll jump in because it's feet.
Jump in with both feet, Gareth.
Absolutely, yeah. Big feet first, yeah. The most important thing is observation. I mean, once people become aware that the foot is involved, I mean, diabetes is a metabolic disease. It affects the whole body. I mean, I often recall various patients when I'm doing these sessions, and there was one that particularly stuck in my mind and said, "Do you suffer with diabetes?" "Yes," she said, "but only in my leg." You haven't grasped the idea that it affects the whole body. So once the patient made aware that they do have diabetes, or once the people within the care home aware that the patient has diabetes, then observation is number one thing. So what we preach in Duet Diabetes session is observation. So every diabetes patient should have their feet washed, dried, carefully dried between the toes, a little bit of moisturizer on the feet, not between the toes, then fresh pair of socks, and make sure the shoes fit, and make sure there's nothing in the shoes apart from their socks and feet. It's very, very simple. What we do at the diabetes training sessions is a lot of the actions that you can take within the home are very simple. But if you understand the rationale behind why we're telling you to do things and what the dangers could be, you've got that depth of knowledge that cements what you're doing on a daily basis. But what we ask everybody to do is wash the feet, dry them carefully, especially between the toes, moisturize the feet, fresh pair of socks each day, and tap the shoes, make sure nothing nasty is dropped into the shoes. With some of the diabetes patients, if they suffer with poor sensation or neuropathy, they can't always feel how tight the shoe is, or things can fall into the shoe. Because podiatry is an interesting profession, we like to have little challenges with one another about what have you found in your patient's shoes. And we've had things like Lego blocks, drawing pins, stones. So we have all these sort of things that patients have come into clinic with, not knowing they've got them in the shoes because they're neuropathic, because they've lost sensation in their feet. They cannot feel what's going on in their feet. And we did a session, Lynn and I, in Norwich fairly recently, last year. And one of the practice nurses invited a patient in to do his diabetic foot screening, took his shoes and socks off, and he actually had a jam jar in his shoe, not a 450-gram one, but one of the little ones you have at breakfast in nice hotels. But he actually put his shoes on that morning with the jam jar in the front of his shoe, rammed his foot in, and the nurse said, "Did you have any difficulty putting your shoes on?" He goes, "Yeah, they took a bit of effort." Now, if anybody who's got a normal sensation, you'll find out fairly quickly if you've got a jam jar on the bottom of your foot. This patient didn't. So it gives you an idea of how neuropathy affects it. They just cannot feel their feet. And so we have to replace that feeling with our eyesight and look at the feet, because they can't rely on their stimulus as normal.
And it's like simple things as well, Gareth, isn't it? Because I remember, you telling the team about socks, to make sure that there's no little creases in the socks, and how if you wear socks that are quite baggy, then they can fold over and cause that friction as well without the person realizing. And you think about if we've got trainers on or something, how many times you pull your socks up because they've gone down and they're uncomfortable.
Yeah, I mean, the sock technology, and I will call it technology, you've got seamless socks these days, so there's no little seam at the end. And you've also got tubed socks, so there's no particular heel, your foot will fit in fine. And also it's the elastic around the leg, so it doesn't dig into your leg at the end of the day. So you've got more gentle elastic. And we're quite a big fan at Duet of bamboo socks. So they're made of bamboo. The newer ones now have seaweed mixed in with it as well, so it's totally sustainable. You're ticking all of the environmental boxes, and you can get them in all sorts of patterns as well. You can have pink ones with flying saucers on if you want to. And certainly when we're going around our session with Hallmark, one of the questions that often came up was, what should we buy one of the residents for Christmas or birthday? So we used to say, well, socks. Why not? Get some nice snazzy socks for Christmas or for your birthday.
No, I'm really pleased you mentioned about socks, because it was something that I was going to ask about, was around the clothing, whether there was anything in particular. So I know Adam loves a bamboo item of clothing. So
Bamboo boxes are amazing. Honestly, they're so breathable.
I was putting my LD hat back on when you were talking there around the importance of washing feet and drying and moisturising. And it took me right back to the amount of people that would have those foot spas and just have their feet. Are they a good thing for your feet? Not a good thing? Should we be avoiding them or encouraging them?
I'm not a big fan of foot spas, mainly because people tend to leave their feet in them for too long, and they come out all wrinkly and horrible, basically. When you're doing a lot of the older generations will talk about just soaking their feet at the end of the day, and what we as professionals like to say, well, fine, 5 minutes is fine, but you don't want any longer than that, really. This sitting there with your feet in warm water and soap for half an hour is not doing any good at all. A lot of the soaps and the shower gels we use actually help dry the skin out themselves. So when we're talking about skincare in the sessions, we discuss skin cleansers, and basically if your shower gel or your soap is lathering, just making bubbles, it's drying as well. That's a secret. So you can use soap substitutes, or the best thing to do is, if you are washing the feet, just wash the soap off immediately and then dab dry, especially between the toes, and a little bit of moisturizer at the end.
Thank you very
I
much.
suppose also with potential neuropathy risks as well, is if we're doing this ourselves and looking after ourselves, and I think, oh, do you know what? I'll boil the kettle and I'll pour it in, and I'll put a bit of cold water in as well, and I'll get my feet nice and warm. You've no idea how hot that water is, potentially. With that reduced sensation, you've no idea how hot or cold the water is that you're putting your feet into.
Yeah,
and
we did.
Either can cause damage, can't it?
Yes, yeah. It wasn't unusual for people to come in with burns because they'd put their foot into a bath. So what we used to say to our diabetes patient was, I don't know if any of you, or if people have got kids at home, but you used to get little nursery thermometers. So when you put in baby in a bath, you used to put this little strip of plastic in, and it was green if it was perfect, and red if it was too hot, and blue if it was cold. So we use those. These days, most patients tend to shower, so they tend to feel the heat somewhere else. But certainly, yeah, you've got to test the water with your hand, and not that gnarly little corner of your elbow that most people seem to do when they were parents. I don't know what that came from. But yeah, and another thing with the talking about neuropathy as well is, you have to remember the patient can no longer rely on feeling things. So if anybody listening, if you've ever walked down the street and there's a little stone got in your shoe, you will stop and you'll take it out. The diabetes patient who suffers with neuropathy, and around about 30% of them do, they won't get that same signal. They'll just carry on walking on that little stone. I mean, Lynn and Julie be tired of this little story, but we once had a patient that came into a clinic, and his reason for coming in was that, and I quote, "My ankle clicks, but only in the kitchen." So we took his socks and shoes off, and he had a drawing pin stuck in his left heel. So the reason he was clicking across the kitchen was his entire house was carpeted, but they just had a laminate floor fitted in the kitchen. So he's walking on the carpet, no problems, walks across a laminate floor, and the drawing pin's going tick, 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 tick on the floor. He didn't come in saying, "I've stepped on a drawing pin." He said, "There's a funny ticking noise every time I put on my ankle." So that gives you an example of how bad it can get. With most patients, they've got pins and needles, sometimes a burning sensation, so they can't rely on their foot being able to feel the environment. So things like shoes can be tight, they can rub and they won't know. Socks can be filled up, like Julie mentioned earlier on. So it's a lot of what we can do for our diabetes patient is to substitute what they can't feel by looking.
Yeah, and also helping, when you're talking there about a stone in a shoe, Gareth, it was also reminded me to mention about deformity, where people's feet can change as they age as well, and somebody could be wearing the same sort of shoes or slippers for years, and it's all very habitual. But if there's suddenly getting some sort of deformity and it's rubbing, but they can't feel that. Again, it's having your profession to be able to help observe that and help them do something about that with alternative footwear, so that they're less likely, because it's all about prevention really, isn't it? It's about trying to stop somebody having a foot problem. Just because you've got diabetes doesn't mean that it's inevitable that you're going to have some sort of foot problem later down the line. It's not at all. So it's how can we minimize that? So, you know, whether it's things like looking at foot care, whether it's improving their blood glucose control, but particularly around feet, it's about making sure that they have that daily good foot care that Gareth explained, but also having this fuller screening examination that some people might be getting from their GP practice. Julie said earlier, you know, it can vary, can't it, the sort of support that you get from different GP practices. And we hear a lot of the time that the foot check, anecdotally, is one of the checks, one of the key checks that people are supposed to have every year, but it's one of the main ones that seems to just drop off. And actually the care sector are in a fantastic position to be able to step in and make sure that happens. And if they're not getting it through their practice, is do what Julie and the teams have done, is have that, bring that knowledge in and that ability, so that they can be assessing their residents or the people that they support, their feet in that fuller capacity. And it is one of the things that the National Advisory Panel on Care Home Diabetes highlighted as one of the key areas that I think they called it satisfactory care, of having a risk calculation and assessment tool for diabetes and foot disease, of making sure that you have that capability to do that within your setting, because that's what we all want to do, is prevent those problems actually in the first place. Most foot ulcers, diabetic foot ulcers are preventable. So it's a little bit about that education and that confidence that can avoid those.
And that risk calculation, that risk assessment tool that Lynn's alluded to there, that's what we use, and the tool we use was developed. Well, I don't know, was it developed by Duet, Lynn? The one that
the format that we did, absolutely, and it's looking at it's basically underpinned by national guidelines, Gareth, isn't it? It's all there. We've just brought it together into an easy use format, really.
So what that does is that identifies residents who could be at high, medium, low risk of peripheral neuropathy. So how we are using it is, you know, obviously every time a team member helps a person with personal care, washes their feet and does, as Gareth says, does the observation, washes between the toes, you know, all that kind of thing. They do that. If they are identified as being at high risk of peripheral neuropathy, we will recheck and we will do that risk assessment again every month, just to keep an eye on that risk assessment, as well as doing the observation. You know, so we're making sure that formal risk assessment is repeated. If they are low or medium risk, then we will do it on a quarterly basis. You know, again, just to maintain that monitoring of the risk, as well as doing the observations on a daily basis as well. And obviously all that's captured in their care plan. So we found that a very, very helpful tool to be able to highlight a resident's specific risk, you know, and then being able to plan care from that as well.
And I think that's important, isn't it, Julie, really, because if you're assessing and identifying that risk level, it means that you can act promptly. So for me, it's about if somebody's feet are in good condition, it's great if they're low risk and you continue to have good daily foot care. But it's the people that maybe are more at the other end that you might have identified a problem. And it's then knowing and having that confidence that actually this person needs to be referred promptly.
Yeah, and I think, you know, And we use it the same as any other clinical risk assessment tool, you know, so everybody will be very used to perhaps using the Waterloo tool or the Braden tool, falls risk assessment tools, you know, all of those kind of clinical risk tools. And social care, we're very, very used to doing them, identifying the risk and then planning the care accordingly, and then revisiting that risk on a regular basis. So we've introduced that foot risk tool in the same kind of manner as the other clinical risk tools we have.
I think something that's highlighted to us hasn't over the years, Gareth, as well, is people understanding the definition of what a foot problem could be and is, or what is a foot ulcer. Some people think, oh, well, it's got to be a particular size or a particular depth, or it's got to be there, you know, that wound has got to be there for a particular length of time. And when they start to realise that any broken skin is defined as a diabetic foot ulcer, and therefore, you know, the action that you need to take promptly to deal with that becomes very different than if they were working off the definition of, oh, well, it's been there for however long, now I ought to do something about it. So I think
it's a teeny little blister, can't it?
Yeah, absolutely. And there's lots of data now through the National Diabetes Foot Audit that highlight the fact that the sooner people that have a diabetic foot ulcer are seen and get the treatment that they need promptly, the sooner that will heal, and the fewer problems that individual will have. So I think it's at the two ends, isn't it? It's about prevention in the first place, of understanding more to try and stop the problems happening in the first place. But then, you know, we've got to be realistic. Some people will develop a foot ulcer or a problem. It's like, okay, now what do we do? What are the guidelines? Where should be going with this?
Yeah, so, absolutely.
Sorry, I was going to say, just before because we've got a few questions in the chat, so just before I come to those, beggars for anything free, Mark and I, for the social care, is there anything online that providers can use to go, actually, this foot screening tool is really, really good, this risk assessment tool? I'm not asking for yourselves to provide as yours, obviously, but I'm just thinking, for those listening to this going, actually, yeah, I really want to do this risk assessment for neuropathy. I want to do this foot screening risk assessment. I want to implement this for all of my diabetes care plans and people at risk. Is there a free guide, a free tool out there that people can go and utilize?
Gareth, there's the guide. Is that I don't know if I'm taking a cookie out of turn, but there's the on the Dermatonics website. They've done the diabetic foot risk. You know, the booklet.
Yes, there's that one. There's also the Frame website, Foot Risk Awareness and Management Education. If they go to diabetesframe.org.uk, that's free of charge. But what we try that's an online tool. It'll give you an idea of things, but really what we try and do with Duet is, rather than just signpost people, if they have a deeper understanding of what can happen, why, then we think the outcomes are a little bit better. I mean, with your diabetes patients, within our UK population, around about 15% of our diabetes population will have a foot ulcer at some point in their lives. If you look at the outcomes, and again, a little bit dark and happy for a moment, but reliable figures just before COVID, we were amputating about 190 limbs a week, and that's just in England. And they are defined as above the ankle. So you're looking about a below knee or an above knee amputation. So we're doing 190 a week. That's just England. Forget Wales, Scotland, and Northern Ireland. That's just England. And if just to put it in perspective, if my mathematics is right, there's about 168 hours in a week. So we're amputating more than 1 hour. Now, if you look at the International Diabetes Federation, IDF.org, they will say that around about 80% of those are preventable. And the reason the amputation is preventable is either stopping the ulcer in the first place, or if the patient does develop an ulcer, then the less severe the ulcer when we treat it, the better the outcome. And those better outcomes are achieved by getting them into a multidisciplinary foot care team, which are usually found in general hospitals up and down the country. So even if you get a problem, the quicker you push it through the system, the quicker you escalate it, the better the outcome for the patient.
I'm consciously rubbing my feet over any sort of knock I feel on my carpet to make sure that I've got all sensation. Health paranoia is real in my craft room right now. I mean, I would know.
there's an awful lot of statistics around diabetes, foot care, infections, etc. But the simple message is, if the patient's aware they have diabetes, if the carers are aware that the patient has diabetes, that's always a good start. Controlling the diabetes is number one in all complications. And then if they do have a foot problem, I mean, Julie and the team at Hallmark are more likely to spot it because they know what they're looking for, and they've got a daily routine, and they've got a tool to work with, and that'll make a massive impact on the diabetes care and on the foot care.
Well, I've stood on plenty sewing pins in this room to know that I have got sensation in my feet. I just want to come to...
We resist the temptation to put some pictures up.
I just want to come to some of the questions that we've had in the chat. So Julie B over on LinkedIn says, sorry I'm late to discussion. Can I ask, in relation to accessing appointments, it is becoming harder, and I think this is probably going to be towards yourself, Julie, this one. It's becoming harder to obtain any NHS appointments, so we find we are funding this care more. My question is to all, really, what have you encountered in our sector in respect to providers covering the cost themselves?
Right. No, we certainly haven't had to cover the cost of specialist appointments. No, I haven't had experience of that.
No, I think for myself as a provider, and as a series of nursing homes, we have health for a reason. And if people are in our services who are under nursing care, everyone's got a duty, haven't they? And they should be covered cost-wise by others. I think. Julie, if you are still watching, Julie, do you want to come back with a little bit more info on your question? Just give us a bit more of a background so we can provide probably a bit more of a structured answer to you. But I myself haven't experienced us footing the cost of this, shall I say? I do love a good pun, so I've not encountered that ourselves.
And we have got experience of having to do GP retainers, so paying GPs to visit the homes, but other than that, not NHS, acute provision. We haven't had to pay for that.
Can I just come in here for a moment? Just quickly, cheekily flicking through, and some people are saying it's difficult to get into NHS podiatry. Yes, it is. It's like looking for rocking horse droppings. The problem is that there's not enough podiatrists in the NHS. Simple as that. So a slight defence that they're doing their best, but I'm well aware that in some cases you may want the podiatrist to come out like tomorrow, and it's just not possible. There are different pathways in different areas. We found this out by going across the country with Duet. There's one part of the country, in my home country, where there's like a walk-in clinic. So if you've got a problem, you can actually go there in the afternoon. And yet on another trust not so far away, it's a 3-month waiting list, and that's just to get a telephone call. So it's very different in different parts of the country. There is an option to go into the private sector. So what we do is we ask you to look and make sure that person is properly qualified, they're well insured, etc. But I'm sure the caring sector is used to dealing with the private sector podiatrists.
And Julie, if that's what you meant when you were talking about paying the cost yourselves as provider, if you were talking about professionals coming in and providing that foot care, then obviously yes, I think we've all got experience of not being able to access an NHS podiatrist or chiropodist. And thank you for. Sorry,
and
Julie.
I think it's so. I was just going to say, I think it's historically in the care sector, we've always in my experience, bought in chiropody services for care home residents. So perhaps in some regions that is extending to podiatry, perhaps.
Yes.
And I could see that happening. I could absolutely see that happening.
Adam, Julie's just commented.
Yeah. Yes, so Julie's talking about the podiatry, isn't she?
Yeah.
So although we haven't experienced that, I can see that is possibly something that could be coming in the future.
Now, Leona, I'm going to start with your question. I'm going to hope Mark can run over to LinkedIn and get the back end of the question for me, because unfortunately the full comment's not come through. But Leona said such important points. Foot health is so important, especially with individuals living with diabetes. There are so many wider health implications, like the increased falls risk you mentioned. It's so important that the visiting foot health providers are qualified HCPC regulated podiatrists who can spot early warning signs in residents and support staff too. There are currently no regs on who can treat the foot health of care home residents. That's worrying when foot health has such clinical, I'm going to say ramifications, Mark, but
has such clinical significance. And then Leona has also put the visiting foot health provider should be on hand to support care home staff with these foot health risk assessments too, while also being on hand to make referrals when needed. This should be at no extra cost to the care home or the residents.
Mark, correct me if I'm wrong. We did an episode, 6-ish months ago now, around foot care in care homes, and we had a chap on who had a podiatry service, and we spoke around the regulations and the sort of lack of, shall we say, and the differences between, say, a chiropodist and someone who's going to come around and cut your nails and what have you. We'll find the link of that and we'll share that out as well, because there was some really sort of good background information for people who weren't fully aware of what the differences between a foot health professional and a chiropodist potentially are. And again, it was eye-opening for ourselves that anyone can go out there, do a day's course or what have you, and then say, I'm a foot health professional, and probably doesn't have that background, like you say, Leona, with the clinical significance that it entails. Right, I'm going to ask, microfilament test, is that what we were talking about? Monofilament test. What is it? Is it a feather? Is it a piece of string? Is it tickling with our fingers? What does it entail? What should we be doing?
Go for it, Gareth.
I'm in my element now. Sit back, get yourself a cup of tea. There's they're basically devices. They're made of plastic and a specialist monofilament, and you bend the filament up against the skin. And when the monofilament bends, it means you're exerting 10 grams of pressure against the patient's skin. If the patient cannot feel that being pressed against their skin, they're said to have lost protective sensation. That's, put it very simply. It's a pretty simple test. It's not something with a little bit of training and a little bit of background. Most people can do it. It's fairly simple. There's a few little tricks you got to know about. You don't test on an open wound. You don't test on hard skin or callus, for example. And there's a few little techniques because the patients will want to say, yes, I can feel it. Most patients want to say yes. So there's a few little things you should be aware of. But it's a relatively simple test. And at the moment, it's the only one that's recommended on the NICE guidelines, the National Institute of Clinical Health and Excellence. So if they're really tired one evening and they want to get to sleep, if you go to nice.org.uk/NG19, that'll give you 30 odd pages of diabetic foot care and its evidence. And the monofilament at the moment is the only recommended tool.
Well,
it looks almost like this kind of long, and it's almost just like a little handle at the bottom, and it looks almost just like a little wire almost. It's not a wire, but so it looks like that. Yeah. So just getting the picture of a feather out your head.
I was trying to find one, but
that's not what you've been doing.
I've been trying to do. There's one in the car, and they're exactly where it is in the car, but I couldn't find one to show. I don't know if you've got one, Gareth, so that people. The one thing with the monofilament, though, with the 10-gram monofilament, though, is that it is very subjective. So somebody needs to be able to know what's being asked of them as to whether they can feel when this like little wire goes against the tip of their toes. They've got to be able to feel, they've got to know how they've got to respond. So people with cognitive impairment, will struggle to do that test. So that's something to bear in mind.
So you've just asked my next question for me then, Lynn. So people with cognitive impairments, what are some of the tips we need to be thinking of around identifying the symptoms with them?
Well, that's a good question, isn't it? That's not an easy ask. But then I think also it's about certainly people in care homes. I think you're in a great place because you get to know your residents so well. to be honest. So you get that kind of relationship. There's an increase in technologies playing a part more and more in foot care, well, in health generally. So from the point of view of somebody not being able to communicate in the same way, there is in order to assess neuropathy, there is what's called a 10-minute screening tool that's a bit like a plaster that somebody can kind of put to the bottom of a particular place on their foot. And it's essentially testing whether that foot is sweating. It's a colour change, and that's checking whether there's been nerve damage to the sweat glands effectively. Is that right, Gareth? Am I explaining that correctly from the neuropad's point of view? So there is the opportunity to, it's not approved by NICE yet. I know that they're looking at more audit data for that, but at the moment it's the only way to properly sort of assess that neuropathy for people that you can't do the monofilament test with. But there's also thermography is starting to play more of a role as well. There's some devices that are on the market that's looking at temperature changes in our feet, and that can help identify problems before they actually occur that might be going on underneath the skin. The foot might look an okay colour and look an okay sort of shape, but actually thermography is looking at all the temperature changes within the foot. So I think that's developments that are appearing at the moment, and I think there's just going to be more and more of that, and will aid people in your roles when you're supporting those that are unable to communicate when they've got pain. You found one. They can't communicate when something is painful, or that they might have bashed their foot. That's the difficulty that you do have. But I think there are tools that are available now, and I'm convinced there'll be more coming.
And I think we just need, though, don't we, Lynn? We need NICE to catch up with this innovation, because, we approached a number of GPs to get the neuropads, which are the 5-minute plaster tests that Lynn's been mentioning, on prescription. And whilst they are available on the national formulary, because they don't feature on the NICE guidelines, GPs won't prescribe them.
Yeah.
So we need NICE to catch up with all of this innovation.
Yeah, absolutely. And my understanding is that's where more audit data has been generated over the last couple of years. Yeah. But you're right, they can prescribe them, but because NICE aren't...
they're reluctant to do so.
However, my argument back to that would be, well, actually, if you've got no other choice, if you've got somebody that you cannot use a monofilament with because they don't know what you're asking them to do, then what else are you going to do, really, if there is no other choice other than using a neuropad? Isn't it better to do that than nothing at all? Because it is all about trying to prevent, isn't it?
Mm-hmm.
It is. I do actually have a monofilament now. That's a monofilament. Okay.
So you wire at the end.
A little button there. The filament comes out the end. I'm not sure if you can make out that filament. And that's where you press up against the patient's foot. So that's it. Nice and simple.
Yeah. And it's not a needle. Some people worry that it's sharp and it's going to be a needle, don't they, Gareth? So it's about explaining what it is.
When you're using this sort of thing, it's very simple. It works out. We did work out how much it cost to do. It's 0.02 pence per patient per year, I think, or something like that. So you extend the monofilament, you test it on their hand. So A, they know what to expect, and B, on their hand, they know what to expect, and B, it's not painful. And then you go down to the foot and you test a selection of sites, and if they can feel each sort of pressure point, then they're fine. It doesn't take long. Once you get the hang of it, you can do that in 2 or 3 minutes.
No, I'm pleased you found one, so we can have a look at what it actually looks like. I thought for a minute you were holding up a pregnancy.
It helps to be married to another podiatrist, so I just had to send a quick text out.
So, conscious of time, and I'm going to ask one final question that I've got, and then I'll hand over to Adam for any last questions he's got. I'm pleased you spoke there around some of those new technologies, because Adam and I have done quite a few shows on AI and digital and innovation and transformation. And I really feel like actually some of those kind of things that are coming through at the moment are really going to kind of shape the healthcare and social care kind of landscape. You must see and hear many myths. And I was keen to know, what is the biggest myth that we can debunk tonight? I'll come to all of you. And I don't know, Julie, whether you've got one not from before you obviously did some work with Duet or not. But yeah,
No.
I'll come to each of you. Sorry, a tricky question. But I mean, there might not be any myths that you're aware of, which would be good.
There's nothing that springs to mind, Mark, I'm afraid. I'm sorry.
Gareth, anything from you?
The main response I get with a lot of patients is, I didn't realize diabetes affected my feet. So there's a thing about they know they have to change their diet. It's something to do with sugar intake. I think people are educating themselves a little bit better these days, so it's not quite as bad as it was. But yeah, I'm not sure about myths. There's a lot of myths around feet, but in terms of diabetes, I think they're just not aware that the foot is actually part of the human body. You've got a quick pub quiz answer for you. How many bones are in a human foot? It's about 26 on average. It can be 28. That's a quarter of the bones in your human body are below the ankle. So that could be a pub quiz winner for you one night. But a lot of people don't actually relate their diabetes to their feet.
Thank you very much. I don't know whether I remember that 26, 28 number, but you never know, it might plant in my brain somewhere. I suppose one myth we have debunked tonight is that actually foot spas are not actually as good for your feet as kind of we are led to believe. A reminder that maximum
leave your feet in a bit too long. Yeah, it's nice to have the little bubbling thing and smell nice. That's great. I'm not trying to spoil it for anybody, but just don't leave your feet in there too long.
Lynn, anything from you that you can think of?
I would say is that some people feel that type 2 diabetes is just a mild form of diabetes, that it's just, it's not so much to worry about. And I think that, well, certainly people that have maybe lost limbs who have type 2 diabetes would disagree hugely. So I think it doesn't matter what form of diabetes you've got to sort of take it seriously. They might be treated in different ways. Somebody with type 1, there clearly isn't ever a moment where they're not having to be on it, because obviously they've got to be managing their blood glucose levels all the time and injecting insulin and what have you. But type 2 diabetes, it's still about elevated blood glucose levels. And if they stay elevated, it doesn't matter whether you've got type 1 or type 2, it will start to have an impact over the rest of your body, such as feet, eyes, kidneys. But we're talking about feet tonight. So I would say, it's people should take that seriously and not...
Could I just add a little something to that? If you look at the literature, the type 2 diabetes patients are actually more at risk of foot problems than the type 1. So Lynn is quite right in saying there's no such thing as mild diabetes. It's a bit like saying, I'm a bit pregnant. You've got it. That's it.
Well, great tip there, Lynn. Adam, any final questions from you or any thoughts there?
No, I mean, I'm conscious of the time and I do want to close this down. I just want to clarify one thing for us, because it's one thing that everyone says, and again, we want this to be educational for everybody. Cutting toenails. Where are we at on cutting toenails?
Cut them straight across and file them around.
Can
Don't
care
dig down the
assistants
corners.
do it?
Sorry?
Can care assistants do it? Or are we waiting for those professionals to come through?
I'll speak from personal experience. What we used to do in the good old days when I was in the NHS, we used to cover care homes. That no longer happens. So most care homes have to resort to the private podiatry, and I'm not. There's some very, very good practitioners out there, but with the non-pathological nails, you cut them straight across, not too short, and you file them. And you're filing them so that when the patient is putting their tights or socks on, they're not catching it, and also they're not scratching the other leg in bed if they're having a bad dream or something.
Perfect. Thank you so much. It's just one of the questions that usually comes up and people usually ask, and it's always nice to get different perspectives. I mean, no, I think tonight's been absolutely great. I mean, to summarize, before we even start thinking about diabetes foot care, have we screened? Have we understood who's got diabetes in our home? Have we looked for those symptoms in other people? And actually, are we aware of everyone who has got diabetes? Screening tools for our feet, risk assessments, absolute must. If we can do monofilament tests, let's get that training. Obviously, let's book Duet Diabetes for our training, because there's some incredible work going on with Lynn and Gareth. And, you know, it might be great buying all these tools, but unless we know how to use them, are we going to do it effectively? So let's get that training in place. Julie, I love your sort of insight into the falls. We use Steady On up in our area. So obviously Footcare comes under that, the footwear people are wearing, the sort of foot conditions, and diabetes and foot care is a link to fall. So it's something to think about when we do our multifactorial falls assessments, as well as our foot care assessments. Care plans, absolute must that we get those updated around the foot care and how we're supposed to be caring for people's feet. Bamboo socks, I love that tip, Gareth. I think it's a really great idea to put something in place that is sustainable and actually is better for the skin, but more so around how we're putting people's socks and shoes on, testing for things. When you were talking about tapping them to make sure nothing's in there, I have terrible PTSD from watching Arachnophobia from when I was a kid, and there were spiders in shoes in that. So I test my footwear at all times, even open toe sandals. I do that sort of eye check test to make sure there's nothing in there, but getting into the habit of doing that in our services. And I just want one last thing around the NICE guidance and the NICE guidelines. I know we've mentioned them tonight. As really conscientious providers listening to this show tonight, we obviously have links to the NICE guidance in our audits and care plans, don't we, when needed? I mean, not necessarily our care plans per se, but around our care planning tools for our nurses, for our care teams. Have we got those links in place so that they can just click in and go and see that NICE guidance so they don't go searching for themselves? Have we got it printed off? Have we got the most up-to-date versions? They are our Bible. We must be working with them. We must be reading them. We must be keeping up to date on them. I know for my audit tool, for our diabetes audit tool that we do each month in the home, I've got a list of all of the most relevant diabetes NICE guidances on there, so that when they do that audit tool, they can just click straight through to it and go and check that themselves whilst they're doing that audit. So essential that we use those NICE guidance and guidelines where we can. Julie, Gareth, Lynn, an absolute pleasure to have you on this evening. A really great show, really informative. I've already shared this with my team whilst we've been talking, because I think there's some really sort of good tidbits from this. Go and download let me get this right, Diabetes Footcare in Dark Skin Tones from Diabetes Africa. We have shared that link tonight. Mark, any closing remarks from yourself?
No, I think just echoing there what you said. Thank you very much to the three of you for giving up your Tuesday evening. I think it's been a really insightful show, and some great resources and links that you've managed to link us to there. So like Adam said, do go and check them out. The guide that Gareth was talking about earlier can be found on the screen at the moment, is in the comments. But yeah, no, thank you very much to the three of you. I suppose the only question from me just before I let you all go is, anybody wanting to find out more, get in touch with any of you, where's the best place? Lynn, I'll come to you first.
Oh, what, to get in contact with us at Duet?
Yeah.
Well, they can go to the website. That's duetdiabetes.co.uk. Or if people want to just email me personally, it's Lynn Reedman at duetdiabetes.co.uk. But there's also links on the website.
Thank you very much. Gareth, I suppose they can find you at Duet Diabetes as well, and also LinkedIn.
They can, yeah, and they can also do me a massive favour by doing 5 things tomorrow morning. So washing their patients' feet, drying them carefully, especially between the toes, little moisturising, change your socks, tap those shoes out.
Thank you very much. And Julie, anybody wanting to reach out to you about kind of the process that you've had at Hallmark and just find out more about Impact and what they can do?
I think probably in the first instance via LinkedIn. I mean, obviously, you know, via Hallmark, but LinkedIn probably the best way to get me in the first instance, and then I can share my Hallmark email address from there.
Perfect. Thank you very much. Adam, over to you.
Wonderful. Well, we've kept you longer than we needed to, but it's been a pleasure nonetheless. I want to give you back your Tuesday evenings to go and do whatever you're going to do, your stale butty from Costa, it may be, I don't know. I'm just guessing that might be someone's evening that they've got planned. Huge thank you to our sponsors, Prosperwell, Care Business Associates Training, and Attis Care by Attis Insurance Brokers, for allowing us and supporting us to continue providing the caring view for zero cost to everybody. www.thecaringview.co.uk caringview.co.uk. All of our free resources, our episodes. You can rewatch this one directly from our website. Subscribe to YouTube. Our podcast is now on YouTube. It's also on Spotify and all other sort of major podcasting sites. Other than that, I just want to bid you all a good night. Please stay safe. Put your heating on if you're cold. Life's too short to be cold. Go and warm yourselves up. But until then, we will see you next week. Have a good evening. Stay safe and take care.
Good night.